treatment outcome of ROP infants with zone 1 and zone 2 posterior disease in North India.
Thank you, sir. So today my topic is the study that we have done retrospectively by observing our case series.
Slides, please. Slides.
Yes.
Yeah.
So this is a retrospective study which we have done by studying the case sheets of babies who were treated for ROP in our center. So just a background, that ROP, as we know, is a sight-threatening, treatable and partially preventable cause of childhood blindness. It's a microvasculopathy of retina arising due to VEGF overdrive. It is multifactorial, but prematurity, low birth weight and unmonitored oxygen supply are the most important factors. And why did we need to do this study was because we were observing a very high number of ROP babies, and because India, like other developing nations, is currently undergoing a third epidemic of ROP, and we lead the world in premature deliveries. A wide variation of poor quality neonatal services adds fuel to the fire, adds more number of ROP babies, and lack of adequately trained manpower who can screen these babies adds more numbers. Illiteracy and financial difficulties of parents add to the low rates of treatment. So before I go again to the study, I'll have to tell you how did the background, the classification. ICROP 3's revised edition, third is now currently being followed. It divides the eye into 3 zones, zone 1, 2, 3 for the disease. Zone 1 is the distance between disc and double the distance between disc and fovea. Zone 2 is the rest of the circle touching the nasal retina, and the temporal crescent shape is the zone 3. So this present study's aim was to analyze the outcomes of all ROP babies treated by me between 2017 and mid-25. Inclusion criteria was only the babies who were in zone 1 and 2 posterior ROP were taken, and only babies who had completed the follow-up, they were taken into account. What do we mean by completion of treatment was that the disease must have been declared regressed completely or progressed to warrant referral for surgery. So the treatment modalities used in the present studies were laser retinopexy of the avascular retina. However, a little tweaking to the early treatment ROP guidelines was done, and we added 2 to 3 rows of posterior to the ridge laser. A 532 nanometer green laser was used. In different centers, different brands were used. I have no financial interest in any brand. For intravitreal injections, again, various kinds of anti-VEGF injections were used, ranging from bevacizumab to aflibercept. For intravitreal injections, 0.025 cc, that is half the adult dose, was used, 1 millimeter from the limbus with a 32 gauge needle on 1 cc syringe. Topical anesthesia was used, and eye was dilated and opened with alphonsopedatic speculum. Most of the procedures were done in OR under a microscope, and rarely some in NICU for sick babies. So total number of infants treated were 266, which forms in this study for zone 1 and 2 posterior disease, which forms 48% of the total babies treated. Rest were zone 2A and zone 3. Few of the babies lost follow-up after treatment, few expired, so we were remaining with 236 babies for statistical analysis, out of which 81 were females and 155 were male babies. This is the zone and stage distribution. Most of the babies are in zone 2P, but however, in our study, large number of babies are also in zone 1, which is about 44%. And again, this subgroup has a very large number of AROP babies, which is approximately 30%. This is a very different cohort from other published studies. Mean gestation age was 29 weeks. However, the babies who were bigger, they added to the, contributed to the mean gestation age being higher, because the minimum GA was also 24. Birth weight distribution is here. It ranged from 650 to 2,700 grams. Mean was 1265 grams. Out of 116 babies who were given intravitreal injection, 77 still needed to be followed up with laser, which is 66%, which shows that injection is not a quick fix solution, and majority of the mainstay of the treatment was still laser. In the distribution of drugs used, there is approximately same number in which bevacizumab and ranibizumab, original research molecule, Eccentrix or Lucentis as it used to be called, was used. Ranibizumab's biosimilars were used in 44 babies, and in few babies 10 aflibercept was used. We saw that babies who were given Avastin or bevacizumab, 60% did not require laser, as other studies have also established that Avastin is the best drug to be used in ROP. These are the outcomes of zone 1 and 2 posterior disease. Most of the subgroups we have been able to achieve regression in 100% of the babies. However, in AP-ROP in zone 1, which is the most aggressive form of ROP, 5 babies had progression and had to be referred, and 1 each in stage 3, zone 1 and 2P had to be referred. Stage 4, all 6 babies were just lasered in order to prepare them for surgery, and they were referred to higher center for surgery. However, this study also shows that if your screening and treatment is adequate, very small number of babies really reach stage 4. And this is analysis of stage 4, that 4 out of 6 babies are from NICUs where no screening was being done, and it is a myth that stage 4 would be seen only in very small babies, because here only one baby was less than 30 weeks of gestation and only one less than 1000 grams of birth weight. So conclusion is that AROP and hybrid ROP is seen commonly in India. It's a cohort quite different from early treatment ROP guidelines. Like India specific screening guidelines, we need our own treatment guidelines also, and with a little modification in ET-ROP guidelines, we can really give very, very good results, 96% in our series. And the take-home message is that strictly implemented screening followed by timely treatment can drastically decrease surgery requiring stages of ROP, and excellent anatomic outcomes can be achieved even in aggressive forms of ROP, and intravitreal injections are not a quick fix solution. Thank you, sir.
So, a good study, Dr. Ajay Kapoor, sir. So, as you are saying that this AROP and this hybrid ROP is different from the international data, if you are...
No, sir. Aggressive ROP, AROP also forms a part of the ICROP3 classification, but most of the studies which are being published in that, the number of AROP babies is less. Since I practice in hinterlands, where in tier 3 towns and cities, there the quality of neonatal services is poor, and AROP and hybrid ROP are all pointers towards poor neonatal.
So, what recommendations you have from your study so that we can incorporate in Indian this classification?
The recommendations based on this study are that even if you have aggressive forms of ROP, it can be very well managed if timely treatment can be given to the babies. And secondly, we need to talk to the pediatricians, to the neonatal specialists to reduce this AROP. Because not in every center treatment would be adequate or would be done timely. So then these babies would progress, because as also seen in my study that AROP in zone 1, 5 babies progressed. We don't even want those 5 babies progressing to treatment, surgery requiring stage. That's it.
Thank you. Any questions, sir?
No, sir, excellent.